Welcome to SLP Nerdcast. I'm Kate.
And I'm Amy, and we appreciate you tuning in. In our podcast, we will review and provide commentary on resources, literature, and we'll discuss issues related to the field of speech-language pathology.
You can use this podcast for ASHA professional development. For more information about us and certification maintenance hours, go to our website, www.slpnerdcast.com. SLP Nerdcast is brought to you in part by listeners like you. You can support our work by going to our website or social media pages and contributing. You can also find permanent products, notes, and other handouts. Some items are free, others are not, but everything is affordable. You can go to our website to submit a call for papers, to come on the show and present with us. Contact us anytime on Facebook, Instagram, or at info@slpnerdcast.com. We love hearing from our listeners, and we can't wait to learn what you have to teach us.
And just a quick disclaimer, the contents of this episode are not meant to replace clinical advice. SLP Nerdcast, its hosts and guests do not represent or endorse specific products or procedures mentioned during our episodes unless otherwise stated. We are not PhDs, but we do research our material. We do our best to provide a thorough review and fair representation of each topic that we tackle. That being said, it's always likely that there's an article that we've missed or another perspective that we haven't shared. If you have something to add to the conversation, please email us. We would love to hear from you.
We just had such a great experience. We had the pleasure of welcoming Dr. David Luterman here with us to have a conversation about counseling in communication sciences and disorders. I had the pleasure of having Dr. Luterman as my professor in graduate school. He is a well-known teacher, researcher, author, consultant, and lecturer, and he specializes in counseling in our field. He was clinically trained as an audiologist, and he considers himself, he is a specialist in the hearing impaired and in counseling. He's written a handful of books, including Counseling the Communicatively Disordered and Their Families, Deafness in Perspective, Deafness in the Family, When Your Child is Deaf, In the Shadows, Living and Coping with a Loved One's Chronic Illness, The Young Deaf Child, and Early Childhood Deafness. He presents at lectures frequently, and he presents at symposia around the world. He's a fellow of the American Speech and Hearing Association and also the recipient of the Frank Kleffner Clinical Achievement Award in 2011. So he's famous, and we got to talk to him for a whole hour, and we're so excited to share it with all of you. I left feeling sort of speechless and inspired, and also full of thoughts that I need to sit on for a while.
I feel like it was a really interesting conversation. I think that it was a very thought-provoking conversation, and I think our listeners will probably might find the same thing. His perspective on counseling is different from perhaps not what we learned in school, but perhaps what we're doing in practice. And I agree. It was a really informative and pleasurable.
He's awesome. I mean, there's really just no other way to say it.
Yeah, he's pretty awesome.
He's completely awesome, and I cannot wait to share this with everyone. It's funny. I took his course when I was in graduate school, so I was probably 23 years old. And now that I'm medium old and I have, more than 10 years of experience in the field, I relearned so much information. And I think my takeaways are completely different than what they were at a different phase of my life. I also wanted to make sure our listeners knew that this course is available for free on our website. Well, everybody's listening for free on a podcast player, but if you would like to use this for ASHA professional development, this course is listed as free on our website and will be forever and a day, just because everybody needs this information. Everybody needs this content. Before we get started, we do need to read our financial and non-financial disclosures and go over our learning objectives. Financial disclosures. Dr. Luterman is a professor emeritus at Emerson College in Boston, Massachusetts. Kate is the owner-founder of Grand Bois Therapy and Consulting, LLC, and co-founder of SLP Nerdcast. Amy Wonka is an employee of a public school system and co-founder of SLP Nerdcast. Non-financial disclosures, Dr. Luterman is a certified member of ASHA and an audiologist and an ASHA fellow. He is also the author of numerous books on counseling listed on our website. Kate and Amy are both members of ASHA SIG 12 and both serve on the AAC Advisory Group for Massachusetts Advocates for Children. Kate is a member of the Berkshire Association for Behavior Analysis and Therapy, Mass EBA, the Association for Behavior Analysis International, and the corresponding Speech Pathology and Applied Behavior Analysis Special Interest Group.
What are our learning objectives for today, Kate?
Learning objectives. Okay. Number 1, identify and define at least 2 features of successful counseling. Number 2, identify at least 2 common mistakes made by clinicians that are barriers to an effective counseling relationship. And 3, identify and describe the importance of support groups. I think there is nothing else we can say to better highlight what is about to happen. So enjoy, everyone. Welcome, 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 Dr. Luterman. Thank you so much for joining us. We are so excited to learn from you.
Well, good. I'm glad to be here. Let me tell you a bit about myself, and then we'll open it up for some discussion among the three of us. I am a clinical audiologist, or at least I was trained as a clinical audiologist, and I started in 1960. That's 60 years ago. And I was doing what I was taught to do in my training program, which is essentially a medical model. A client would come in, and I would take a careful case history. I would then do my testing, and then I would counsel. And counseling was seen as a separate entity at the end of the interview and the testing. And the counseling was always information-based. So it was an explanation of the audiogram, and if appropriate, it was a discussion about hearing aids and what the next step was for them and what might be the cause. So it was in terms of causation, in terms of habilitation or rehabilitation, but there was no dealing with the feeling aspect of it. In fact, I remember in my grad school the injunction I had was, if there's feelings around, refer to the social worker, which we had associated with the clinic. So I had that notion about counseling as information giving. And then I proceeded to start my clinical career, and I followed through on that. After about 2 or 3 years, I began to find that clients just weren't absorbing anything that I had said. After a while, it becomes almost routine, the information giving at the end of the testing. And they would, when they would come back, they would be asking me questions about stuff that I knew I had covered, and I'd covered sometimes 2 and 3 times to be really clear with them. And they seemed to be listening, but apparently they heard almost nothing that I had said. And then I found that there was, way back then in the 60s and 70s, a fair amount of clinical research indicating how little clients retain of the content that is given in an interview. And this was true for me as well. And I began to explore that a bit, and what I discovered, looking at the literature further, is that when people are emotionally upset, they can't retain content. Your brain goes into a fight or flight mode, and you're not in your left brain, you're in your right brain. I think we've all experienced this. Mm-hmm. When you're emotionally upset, you just can't read. You try to read something, and you read the words, and they don't connect in the brain. There's like a disconnect. And it's a phenomenon that occurs normally when we're emotionally upset, we go into fight or flight mode, but cognitively we shut down. And this is a survival characteristic that we have that's built into our neurological system. So it doesn't matter how prepared a client is, but when you make a diagnosis, and this would be true if you tell them that their kid is on the spectrum or even has an articulation disorder, certainly if he's developmentally delayed, you're going to have that sort of shock response, that fight or flight response, and cognitively they shut off. I used to think, well, okay, I was wasting my time maybe giving content, but it's not benign, because what happens is when you give content early on and the client is not ready for it, not emotionally ready for it or physiologically ready for it, you contribute to their feeling overwhelmed and scared and inadequate. And all that are very negative things for a positive outcome with a client. So I found that in order for me to be effective as a clinician, I needed to deal with the emotional realm. And Asha, way back when, defined counseling as both cognitively and personal adjustment counseling as aspects of it that we as clinicians in the speech and hearing field should be comfortable with. So there was that personal adjustment piece. But what I realized is you really can't do one without the other, or you shouldn't do one without the other. In other words, the content has to be intertwined with working with the emotional state of the client. We can't ignore it. If we do, we're not going to be effective. And I think that's what happens. I think right now, and I'm looking at the research that's out there, the predominant way of counseling, for at least for audiologists, has been this medical model. We've inherited it. It's comfortable. It's self-protective. And a lot of people in our field are very uncomfortable when we're dealing with the emotional aspects of it. But the emotional component is there. We are dealing with people who have lost the life they thought they were going to have. And we're really doing grief work. And then what we must do is we must become comfortable with that feeling component in order to be effective clinicians. We can't do one without the other. So I have sort of built my career on trying to help people in our field, clinicians in our field, become more comfortable with that emotional aspect of it. And I recently wrote a paper on teaching counseling, and the reviewers asked me to write a definition of counseling. Now, I've been teaching counseling for 40 years, and I've written a number of books about it. But nobody had ever really asked me to write a definition of counseling. So I sat down and wrote it. It's a bit of a mouthful, but let me give it to you in pieces, and then I'm going to just open it up for discussion. So counseling are the components of the clinician-client relationship that promotes self-enhancing behavior in the client. That's one piece of it. What happens is when clients have a lot of feelings, they behave in ways that are not self-enhancing. So a lot of anger gets displaced around. They're feeling overwhelmed and scared, so they go to seek somebody to solve their problems for them, and so on. So we need to deal with that behavior which is not self-enhancing. And we can promote self-enhancing behavior in the client through the judicious provision of information, while also allowing for the expression of painful feelings in an emotionally safe context. And that's what we need to do. We need to be able to build in to the relationship where they feel emotionally safe to begin to talk about how they're feeling, to experience their feelings, to cry. Because what happens to our clients is they're not given permission to feel bad. They are, everybody conspires, including people in our field, to try to make them feel better. And that's probably the worst thing you can do for somebody who's in pain. It seems counterintuitive, but what you do when you try to make them feel better is you invalidate their pain. I remember one parent, as she was sitting down in a support group, she looked me square in the face, and she looked at me and she said, "You're going to make me cry." And I looked back at her and I said, "No, I'm just going to give you permission to cry." And she started to cry. See, when we try to make them feel better, we invalidate the feelings. We tell them they have no right to feel pain, and yet they're in a very painful situation. So it's that safe context that we need to provide where parents or clients can feel and experience their painful feelings. And if you're successful counseling results in an empowered client who has the information he needs and who is emotionally grounded. And by emotionally grounded, I mean what one parent said to me once. She said to me, "You know, I have the same feelings I used to have, but they don't control me anymore." And so we're not going to try to do away with the feelings. We're going to just let them not control the behavior. And then successful counseling is also transformative. People should come out of that growing. They should be better off. And it's one thing I've learned over the years. I never feel sorry for our clients. They're in a painful situation, not of their own making very often. And I know that if I hang in there with them, that they are going to grow and learn from this. These disorders are powerful teachers. And so they can be transformed into a more grounded human being. So, Kate, name me, what would you like to know?
I feel that you've touched on so many wells of information. I think what I'd like to start with is the concepts of, it's really twofold. The first is deep listening, which is something that you reference a lot in your writing. And the second is self-care, which is something that you touched on briefly about being grounded. And I know that there's a relationship there. But can you tell us a little bit more about the importance of deep listening and self-care?
Okay, well, yes. Let's do listening first. Listening is, I think, one of your most important tools. It's not always seen as a tool. And because students are trained and clinicians are trained to perform, to be doing, to be showing how smart they are, to be helping, and yet sometimes, most of the time actually, the most helpful thing you can do is listen to the client, because nobody is bothering to listen. They're all busy telling them what they should do and how to feel better. Instead of listening carefully, and what I mean by that is listening and listening selflessly without having any agenda. And then being able to listen to what Carl Rogers calls the faint knocking. See, the language we use is really a map of a territory. And underneath the territory is very often how we're feeling or what the feelings are. So we need to listen to the map very carefully to see what the territory is described. But let me give you an example of this. A question you're going to get almost invariably is in etiology. What caused my child to be autistic, or what caused my child to be deaf, or my husband to have a stroke, or any of those questions about causation. And on the surface, you can just look at that question and you can see it as a content-based question, and you can give them the content from your courses. But I can tell you right now that that's going to be unsatisfactory, because most of the time people already have an idea of what autism is or deafness is before they come in. They've been on the internet, people have told them all kinds of things. And so when they ask you that question, they're really not asking that question. The underlying feeling there is probably guilt. They're really asking is, did I do something to cause my child to be deaf or autistic, or my husband to have that stroke? And they're really dealing with guilt. And so it can be much more helpful when you're listening carefully to the client to be able to indicate in some kind of way in which you respond. You can say, sometimes it's very easy to feel guilty that you may have done something to cause your child to be deaf. Is that true for you? Might be a way to respond to that rather than to the content level. So that's what I mean about deep listening, being able to hear that faint knocking that Carl Rogers talked about, which is related to the emotional state of the client. What is the emotional state of the client there? And so that's the listening piece of it. I think there is no single more important aspect of counseling skill than that ability to listen, to allow the client to come to you, and then to be able to respond to the territory. And then the second question you had was about care, self-care. And this is something I find, especially with women in general. I don't like to generalize this way, but women are acculturated to be taking care of everybody else. And to take care of themselves usually involves a certain amount of guilt. But yet, we are the most important tool in the clinical interaction. So by self-care, what I mean is that we have to be sure that we're comfortable with ourselves and that we're able to listen. And if we're running on empty because we've had so many clients that day, we're not going to be able to listen, and we're not going to be effective. So I always tell my students, one of the most important things you can do for your clients is to have lunch. And they always laugh at that. But no, you need time out. You need time to just get yourself together, to get yourself what I call centered. I teach my clients, the students very often, to meditate for a few minutes, just go back and sit and be comfortable with their feelings. And then when you're centered, you can be much more effective. Is that enough, Amy, or?
I feel like you are. When I listened to you speak, and when I read the writing for this, you also wrote my counseling textbook for grad school. But I think I think that it's such a big topic, and I guess I appreciate the examples that you give in your writing about how to learn to be a listener and what types of questions to ask, because I think, you're making the point that it's a skill just like, for a speech pathologist, transcribing an IPA is a skill. Like it's a skill that has features that can be learned, but I think it's hard to know how to do that.
And we don't
Yes.
get a lot of training in it necessarily, which is another thing we wanted to ask you about in terms of, for our listeners out there who maybe didn't have the pleasure of having you as a professor or one of your books, do you have recommendations for how clinicians can acquire these skills, no matter where they are in their career?
Well, I have a confession to make. I have never had a counseling course. They weren't in existence then, and I've never taken a counseling course in formal ones in school either. In the psych department. My learning has been all self-taught by looking at and reading books, but it was also by doing a lot of personal growth experiences. And as I get more comfortable with myself, then the counseling skills sort of get added on. A textbook helps, like the counseling textbook, one I wrote, but there's several others. There's one by Holland and one by DeLolo that are pretty good too. So reading about counseling in our field and then counseling beyond our field into the psych literature is helpful. But I think the most helpful thing for me has been keeping myself grounded, that self-care that I talked about. Because when I do that, then you can listen better and you somehow hear better. But what I can do is, let me talk, I can talk about two ways. There's two ways of going at this. One is we can talk about what you should be doing, but I think there's another way to go, which is, let me talk a few minutes here about some of the mistakes we make, what I call counselor caveats, things you shouldn't do. And if we strip away a lot of the things that get in the way, what's left is the good stuff of relationship. We're really talking about relationship here and what makes a relationship work. And what gets in the way of a relationship, if we can strip that away. One of the things that's a real problem in our field is what I call overhelping. It's when we do more than we should be doing, and we tend to create a dependent client so that they're not empowered. It gets in the way of empowering. Clients want us to solve their problem. They want us to be a fixer and to fix the problem. If we take that on, which is very tempting for people who have a strong need to be needed, and there are a lot of people in our field who have that need to be needed, then we create dependent clients who are just looking to us for the next answer. I had a poster in my office and it said, "Give me a fish and I eat for a day. Teach me to fish and I eat for the rest of my life." And that's what counseling is about. We're there to teach fishing. And so not to overhelp to the point where we would create a dependent client, because that would be giving them fish. So we have to trust that the client themselves is going to be able to solve their problem eventually. If we give them enough support and enough information, they'll make good decisions for themselves. We need to understand denial. Denial is a coping mechanism. It's something that the client goes into right away. It's a way in which we self-protect ourselves. And so we may admit that our child is deaf, but it becomes very hard for us to put hearing aids on the child because looking at the hearing aids means that he's deaf. And so very often you have parents who are just remiss about putting hearing aids on. And it's very easy to start blaming the parents. or trying to rescue the kid from the parents, both of which are bad mistakes. We need to understand, and we need to put the parent in as our client, understand that denial is a crisis of confidence. It's that's the only way I can cope right now, by emotionally pretending that this is not there. Denial gets in the way so often, and because it's just not understood well. There's implicit expectations that get in the way of relationships. This is when we assume something, and the other person, and we haven't really checked it out. It's what's called contracting, being very explicit about what you want and what you expect from the client. And I always ask clients, what do you want from us? What are you hoping will happen here today? I do this with students in my class. Always start off a class with, what do you need? And so we then see where there's a match. Very often, clients want you to be the Annie Sullivan and solve their problem and take the kid and be the fixer. And if you've been listening carefully in here, you don't want that role. It's a bad role, because you're not going to get a good result long term with that kid, because you only have the kids for such a limited amount of time. We need to spend that empowering the parent and not diminishing the parent. When overhelping diminishes the parent's self-esteem. The thing that we also have to avoid is stereotyping people. It's very easy to do it, to try to put them in a box. I had a prof who was really good about counseling. He had it intuitively. And what he used to say is, you remember, you have to see each client as a wonderful experiment of one. And once we can do that, set aside expectations, then we can hear clients and see clients, and just be present for the client. And then the last thing that gets in is what I've talked to before. That's all about that cheerleading, thinking our job is to make the client feel better. And that's going to invalidate their feelings of pain. And they won't have that kind of honesty, the kind of openness in the relationship that I think it needs in order to be successful in promoting growth in the client. So that's some of the things that get in the way of the relationship. And if we can sort of get those out of the way, then, technique flows from this. And the best technique is, as I said, listening and not always responding with content. Content is the easy thing to do. And we do have a content mandate. As I've said at the outset, we do have to get information, but it's the timing of that content. So very often when clients ask you a question, there's an underlying as I talked about before, about the feelings, but very often they want a confirmation. When people seem to be asking for advice, 95% of the time, even closer to 100% of the time, what they're really seeking is for you to confirm what they really secretly know. So if somebody asks you, what do you think of my boyfriend? Yeah, don't answer that with content. Trust me. That isn't what they want or need. What they want is confirmation of some position they have. So the way to respond to that is what I call a counter question, which is, well, it sounds to me when you're asking me that question that you have some doubts. So could you tell me how you feel about your boyfriend.
Mm-hmm.
That's a much safer way to do that.
Mm-hmm.
Now to get back into our field, like if they ask you what do you think about cochlear implants, or is that school for the deaf a good school for the deaf, or anything else? But they seem to be asking for advice. They seldom are. They're asking for confirmation. And what you want to do is throw them back on their own heels, on their own self, so that they really answer the question for themselves. They sometimes get kind of angry at you for that, but it's the best teaching technique you have.
That sort of brings me to one of the other questions I had going through your readings. You framed it so well about these obstacles to relationships in terms of denial. And then earlier you mentioned misplaced anger. And
Yeah.
I'm wondering if you have, I don't know, wisdom, you have lots of wisdom about counseling parents or working with families where there is misplaced anger or denial that is such a roadblock that the clinician might feel a little powerless in terms of either, the family is asking for a treatment that is against our code of ethics, or, they're being butt up against our evidence-based practice, or there is misplaced anger where there's name calling or inappropriate behavior on the side of the family. What tools would you recommend, given the realistic restrictions of our work environments, to navigate those spaces?
What you need to understand that's the non-productive behavior that I talked about, which really comes about because people haven't heard and listened to the client. Almost all of that is fear-based, but that's what you need to understand. We're dealing with people who are grieving and they're feeling overwhelmed. These are the two principal feelings that they have. They're in pain and they're feeling overwhelmed and they're scared to death. And what we need to do is respond to the fear. Let me give you an example which I saw from that prof that I saw, Gene McDonald. He was my mentor in graduate school, and what he taught me so well. I watched as he was counseling this family with the kid with a Down syndrome kid, and the father was this big burly steel worker. And he comes in to the meeting with his wife. He says, if anybody tells me my kid's retarded, I'm going to punch him in the nose. And McDonald, without missing a beat, looks him square in the face and he says, you must love this child very much. And the guy started crying. And he just blubbered. So it's the feeling underneath there. A response that helps me a lot with parents, or not just parents. I've worked a lot with parents of deaf kids. That's where I went on and after I left clinical audiology. So I always tend to refer to them in that way. The response that I find very helpful is, this must be so hard for you. So I don't respond to the anger. I respond to the pain that's there. Or I respond to the fear. It's pretty scary right now for you, isn't it? And mean it. If you say it that way and mean it, it sets the parent back. I don't get defensive. The worst thing you can do is get defensive, and it's hard not to. But to hear the pain, hear the fear, and respond to it.
I think in part that for me, when I listened to you speak and in reading the content that you had sent to us, I think part of it is also about just shifting from that role of being the fixer. And if you as the clinician kind of give yourself permission that that's not your job, I think it's a little easier to step outside and have a more human relationship with the person, because you're no longer having all the weight of all of these responsibilities, that actually aren't that productive in the first place.
I was actually thinking something somewhat related, but having been in situations like this before, it really makes me think about how grounded you need to be, because when someone is, yelling at you or threatening to punch you in the nose or calling you names, as a clinician, as a human, I have a fight or flight response. So then, being really able to ground yourself and separate yourself from, and not take it personally. I think that those two things combined are just of utmost importance, and not something that we talk about a lot as a field.
I have one more question also, which I think Kate and I talk about this a lot on our show, and the fact
I know what
that
you're going to say.
the fact that we're a reimbursement driven model and all of the negative repercussions that can have on our continuum of service overall. But I think a real challenge with forming genuine relationships with people is this like pressure of time, right? So whether you're in an outpatient setting or you're in a school, we have such limited time with the families. And I didn't know if you had any tips about how to operate in the treatment model that many of us are operating under.
Yeah, it's what I've talked about really, is embedding the information with the emotional responses, and that's how you're going to be effective. If you're going to, just try to deal with the content and information aspects, it's a waste of time. In fact, you're damaging your client when you do that. So you need to realize that, and hopefully reimbursement can. Somebody asked Carl Rogers that, because what I'm talking about is the non-directive counseling that he grandfathered. He said, what do you do if you have 20 minutes only with a client? And Rogers looked him square in the face and said, you do 20 minutes worth.
Yeah.
It's a question of how to be effective with your client. And we have to sort of recognize this as a profession, that the most productive way we can spend our time sometimes is just selflessly listening to the client. It pays huge dividend later on. The payoff may not be right away, but what happens is you get an empowered client who then you can start really dealing with content a little bit later, but you embed the content there too. It's a matter of being effective. So I hope we just don't get pushed around by insurance people. Or I know the pressures are there.
Yeah, I mean, I remember working in a hospital setting where I had to see X number of patients a week, and there was, to your point earlier, the best thing you could do is eat lunch. I barely had time to eat lunch, and it wasn't necessarily, I think that, burnout is high. I know you've mentioned that a lot in your writing about burnout. And I think I can't help but feel that the funding model and lack of funding for indirect service, frankly, is really a contributing factor there.
Yeah, and I think we have to change it. We have to work at that. We have to create environments that make it possible for us to be effective in our job.
Right.
Such a good point.
And if you have lunch, you can be more effective.
Right.
And you can go outside and take a little walk and get some air, and give yourself a break. You'll be more efficient. You'll use your time better.
I was wondering about the role of support groups. You mention a lot in your writing about the power and importance of support groups. Can you tell us a little bit more about that?
Oh, I am such a fan of support groups. I started when I got disaffected. I just didn't like clinical audiology. So I decided I'm going to transition myself out of audiology, clinical audiology, and I'd start a nursery school for parents of young deaf kids. And I did this in 1965. It became one of the first early intervention programs around. I didn't have any of this vocabulary at the time. But what I knew what needed to happen was you needed to focus on parents. And, it's everybody, it's very frustrating to me because everybody agrees in early childhood deafness and in autism how important parents are. Nobody's ever going to argue with you about the importance of parents. And they seldom do it, though. And what you need to do, and it causes a paradigmatic shift of saying, the parent is the most important piece here. I'll get to the sport group in a minute, but I just went a long way around here for a minute. It causes a paradigmatic shift when you put the parent in the center. I remember talking to a group of itinerant teachers of the deaf. This was in England, and I said to them, how many of you think the parent is the most important person? And everybody raises their hand. And then I said, how many of you go into the house with a toy? And everybody raised their hand. I said, so why are you bringing a toy to the parent? They don't need it. And but it's just a reflective of how we go about things that people say they're parent-centered, but they're not really, because our training is all geared towards the identified patient, the kid, or the adult with the stroke, or so on. So I started a parent-centered program, and we had a nursery school, and we had the parents observing, and then we had the parents doing therapy. But I knew something else too at that time, although I couldn't have articulated it. I took the parents upstairs, left the kids down in the nursery, and had a support group. And I can still remember, this is in October 1965. I can still remember it vividly because it made such an impression on me. I didn't quite know what I was doing, and I didn't have the vocabulary, but intuitively I knew that they needed to be together. And that group was so powerful. We just went around the room, and I had everybody introduce themselves. And I had these short speeches as an audiologist content, but here I was committing myself to a whole semester worth. And I said, and I was scared to death, I said, well, I just think we need to just use this space as you need to use this space. And I shut up. And then the torrent started. The parents just started to talk. And what I realized right then, that what happens when you have a catastrophic event in your life, it's emotionally isolating. It sets you apart from all your ordinary places of being. You're now different than anybody else, and people don't understand. They all, again, what I was talking about, conspire to make you feel better, which just tends to isolate you and invalidate your feelings. So when you can get into a room with a bunch of people that are experiencing the same thing you're experiencing, you get validation for your feelings and for your experiences. In no other place can you do that. And every time I do a support group, particularly the initial one, it's the same thing. There's like a palpable whoosh in the room when people recognize that here's a place I can be safe Here's a place that I can talk and people will understand. Now, I have taken this model, this support group model, and I have used it in all kinds of contexts, including people giving up smoking and smoking cessation groups and caregiver groups of one kind or another. Experience is always the same. It always is that validation of my experience, and the only place I can really get that is a support group. I can't imagine any program without it. It's the most valuable tool that we have, and it's a great gift that we can give our clients. So first of all, you got to see the parent or the caregiver as your client. And two, you got to give them that kind of safe environment where they can talk to each other. And it's a wonderful experience for yourself. I've learned so much. These parents have taught me so much. So yeah, I'm a big fan of support groups. I couldn't imagine a program without it.
I was just, when you said that before, as you're describing it, it sounds incredible. And yet I don't know of a single program that has one, which is, I mean, obviously we're unearthing a lot of deficits in our, in the normal day-to-day of our field. I'm sure, or hoping that a lot of our listeners will leave this conversation and try and advocate for a support group. I think a lot of speech pathologists and possibly audiologists, but I'm not an audiologist, may not feel that running a support group or starting a support group is within their scope of competence or something. So for example, in one of my settings, we're consistently advocating for a social worker because the social worker is the role that will initiate these kinds of endeavors. Do you feel that a speech pathologist or an audiologist has it within their scope to spearhead these kinds of projects and start support groups?
You bet I do. In fact, I don't want the social worker in there.
That was the answer I wanted.
Yeah. Well, I mean, the social worker comes from a pathology point of view. We're not dealing with pathology here at all. Mm-hmm. We're dealing with us. We're dealing with people who are in a catastrophic situation, not of their own choosing. Their life is turned upside down all of a sudden once you find their kid is deaf or autistic or whatever. And it's grief work. Grief is endemic to our humanity, and it needs to be within our scope of practice. It makes it so much easier. This is not pathology. These are people who are emotionally upset, not emotionally disturbed. And it's much more relaxing for them to be with a speech pathologist or an audiologist than with a social worker.
Such a good point.
That gets into the pathology piece of it. In fact, I get some blowback from psychologists and social workers sometimes because I also say, I never refer any of our clients to speech pathologists, to social workers or psychologists, and they always look at me. I say it's not their problem; it's my problem. And I just identify it as such. When, there are clients who really do need that need professional help. But I don't make that referral. I just tell clients, this is as far as I can go and I want to go. This is parents who are having a lot of problems with their marriage, for example. I don't go there. I just say I want to go. This is beyond my scope of practice, is what I will say. But I leave it there. I don't say you should go and see a marriage counselor because that's it may not be within their value system at all. And that's the same way I just don't bring a social worker in to work with them because that may not be their value system either. So. And the discussion will go on, then where do I go? And then we can talk about that. And I'm always looking for them to make a self-referral. When it's a self-referral, it has a much greater chance of being successful than if they're going to the social worker because I sent them there.
Mm-hmm.
And it's not necessarily their problem. It's my problem, certainly, because I don't want to go there.
That makes a lot of sense. I am hoping that all of the people who will listen, who are listening to this course, take a nugget from that and advocate with their administrations. And, gosh, after hearing this whole conversation, I hope we all do a lot of things. I hope we all do a lot of things differently. This has
that's
been
my goal.
Right.
My goal is to make you upset. My goal is to make you upset. And upset people will make changes, you see.
Right.
Happy people bliss out.
Right.
They have no investment in making some changes. I love the book way back when. I love the title of the book. It was also good content. It's called Teaching as a Subversive Activity. And they talked about that. The teacher's job is to undercut the learner to a certain extent, to make the learner uncomfortable.
Good job. You did a really good job.
So they get moving around. Oh, good. So I succeeded?
You did. You did. Oh, my gosh. Well, I mean, we're uncomfortable, but I'm not that uncomfortable, but I think it's really refreshing. And I say this to my mentees a lot, you're never going to learn until you're operating in some moment of discomfort. I mean, even just thinking and reflecting back on ourselves as new graduates, that first time you're sitting with a client, you're being looked at through the mirror, you're sweating, you're nervous. These moments of feeling nervous are so important. And I think all of the things that you've just touched on highlight so many deficits that I can only speak for myself. I have not embraced as deeply as I could have or should have, but will. And I feel pretty comfortable saying that as a field, we don't have an emphasis on these areas. And so I'm so grateful for you pushing us to a place of discomfort so that we can share all of these things with our listeners.
Yeah, you should always be operating on the fringes of your competency. If you're comfortable about what you're doing and not learning anything. I have a whole list of aphorisms, clinical aphorisms. Did I send those on to you?
You did.
Yes,
You did.
So good.
Oh, good. Oh, all right. So, yeah, I think you might find them helpful too. If somehow you could share it with the listeners, it would be, I think, helpful.
We can list them on our website that will correspond to this episode. So we will put them up there for everyone.
Oh, good.
Thank you so much for joining us. This was an unbelievable pleasure. Before we close the episode out, do you have any advice or closing remarks or more words of wisdom than you've already given us?
I think you got enough.
Well,
sounds like you got enough. You got to go digest it for a bit and come back. We'll talk some more.
I think digesting is a good idea. We're so grateful for your time. Thank you so much for joining us.
You're very welcome. You take care.
Thank you.
Good luck
Too.
for both of you.
Thank you. Thank you so much.
Bye-bye.
Thank you so much for joining. As I'm sure, I hope all of you are walking away from this conversation feeling like you have things to digest and feeling empowered to effectively make change in our field. If you have any questions, please email us anytime, info@slpnerdcast.com. We really, really enjoyed this episode, and we are so excited to have been able to share it with all of you.